During residency, you will likely find yourself caring for patients with cystic fibrosis, or CF for short. CF exacerbations are not usually covered intensively in medical school. This video is designed to serve as a primer to help guide your understanding and treatment of hospitalized CF patients. We will touch on general principles of CF, what constitutes an exacerbation, what specifics should be incorporated into your HPI, and some common treatment modalities. This is not designed to serve as a one-size-fits-all approach to care, but should help to answer some common questions that you may encounter when caring for a person with CF. Let's start with the basics. CF is a rare autosomal recessive disease. It affects approximately 30,000 people in the US. The average life expectancy of a person with CF has been progressively improving and is now around 38 years of age, with many living much longer as therapies continue to improve. CF is fundamentally a disease of mucus. It occurs because of absent or defective CFTR protein that is responsible for the movement of chloride from the inside of the cell to the outside. This leads to a decrease in the amount of cell surface fluid, which impairs ciliary function in various parts of the body, resulting in the accumulation of mucus. Mucus builds up in the lungs, the pancreas, and the intestines. The common clinical manifestations that you will encounter in the hospital are recurrent sinus and lung infections, hemoptysis, blocked bile ducts leading to cholestasis and liver damage, pancreatic dysfunction, and poor nutrient absorption in the gut leading to malnutrition. So why are people with CF typically admitted to the hospital? You may have heard the term cystic fibrosis exacerbation, but what does this entail? We typically define a CF exacerbation as a decrease in lung function. In some cases, patients will present from the ED with respiratory distress and have no PFTs done. In these cases, we typically define an exacerbation as a change in the patient's respiratory status, characterized by any number of symptoms including shortness of breath, cough, increased sputum production, change in sputum consistency or color, just to name a few. Compared to some other patients that you will care for in the wards, patients with CF can appear very well on admission, but still be experiencing drastic decreases in their pulmonary function. They will often be admitted for a long period of time for IV antibiotics and aggressive airway clearance to restore and preserve lung function. Anytime a patient is being admitted for an exacerbation, you want to take a detailed history, some specifics that you should think about. Specifically asking about any changes in sputum production, consistency, color, if they've been having chest pain, and hemoptysis. CF patients are more prone to developing spontaneous pneumothoraces and hemoptysis, both of which can lead to significant morbidity and mortality if not addressed early on. When patients are admitted for exacerbations, antimicrobials and airway clearance will often be the foundations of treatment. We often use sputum culture data to drive treatment. Every time a patient presents to the CF clinic, they will have either an expectorated sputum sample or throat swab. They will also have these done from prior admissions as well. The most common bacterial pathogens in the sputum are Haemophilus influenza, Staph aureus, Pseudomonas aeruginosa, Burkholderia cepacia, E. coli, and Klebsiella. Always obtain a fresh expectorated sputum sample during each admission if it has not already been done in clinic prior to the patient's arrival. Patients are often skilled in providing an adequate sputum sample. There are some patients, including those on modulator therapy, who are unable to provide an adequate sample and will often need to be swabbed. Pseudomonas tends to be the predominant pathogen in adulthood and gets double coverage with antibiotics. Typically, we use IV tobramycin, which is given once a day, with levels checked at 2, 10, and 18 hours at our institution. We'll also typically treat with ceftazidime or Zosyn, depending on the culture data from the patient. You should stop their inhaled tobramycin or Caistin unless you hear otherwise from the pulmonary team. The other important part of treatment is airway clearance. This we will dive into with help from one of our respiratory therapists, Stacy.
Hi, I'm Stacy Caddick-Dowdy. I'm the respiratory therapist here at the Cystic Fibrosis Clinic at Rhode Island Hospital and Hasbro Children's Hospital. And we're going to talk about airway clearance today, why it's important, and different ways to do so. So airway clearance is important to move that sticky mucus up and out of the lungs. So any kind of airway clearance helps to thin and loosen mucus or get air behind pockets of mucus to make it easier for the patient to cough it out. So order of therapy is very important. First, you want to do bronchodilation. So you want to give a bronchodilator, whether that's via nebulizer or meter dose inhaler with a aero chamber to help relax and open the airways up so that other medications can get in easier and mucus can get out easier. Secondly, you would do hydration therapy. So if the patient is on something like hypertonic saline of any strength, so there's like 3, 7, and 10% hypertonic saline, you would do that next. And what that does is help draw fluid from the lung tissue to make a deeper layer of fluid in the lungs for the mucus to slide on, and those cilia can beat easier when they have enough room. Next, you would do pulmozyme or a mucolytic to help thin and loosen the mucus. So pulmozyme is enzyme based, so it helps break down the proteins in the mucus to help thin it out, almost like butter melting. And then you would do airway clearance. Some of these things can be also combined, right? And that would be up to the respiratory therapist in charge of doing the therapies, or the patient while they're doing the therapies. But next you would want to do any sort of manual airway clearance, so something physical to move the mucus. And this is where the airway clearance comes in. So the VASC, the aerobica, which is oscillatory PAP, manual percussion, autogenic drainage, active cycle breathing techniques, anything that's going to physically move the mucus. Once you've physically moved the mucus out of the way, that's when the therapies come in that you want to stay in the lung tissue. So whether it's inhaled antibiotics, right, they need to stay in there to do their job, or inhaled steroids. They also need to stay in there to do their job. So those go in last, after everything to move the mucus. Oh, let's show you some. Patients who have these at home might bring them in during a hospital admission, and then just connect to whatever machine you have in the hospital.
Got it.
And the way this works is it's gonna fill with air. So there's an air bladder inside.
Okay.
It's gonna fill with air to put some pressure on the chest wall, and then it's gonna oscillate that air. So it's gonna be like pumping air in and out. And what that does is make airflow within all your little airways.
Okay.
That airflow serves two purposes: to help get air behind pockets of mucus, as well as to thin and loosen the mucus.
Okay.
So the proteins that bind mucus together don't like that movement, and they kind of just fall apart. Right?
Okay. Yeah.
So you're gonna hear some oscillations in your voice if you were to try to talk or sing or whatever, and that's how we know that it's moving air and that it's working.
Yeah.
That's one way to know that it's working.
I'm definitely feeling some oscillation.
Yes. Or even if you were to just put your hand like in front of your nose and mouth, you would feel little pulses of air.
Oh yeah.
Can you feel them? Yeah. So it's doing that within all your airways right now.
Okay. Can't imagine doing this for 20 minutes.
Right. So a lot of patients do pauses. So they'll do it for 5 minutes and pause for huffing and coughing, or 10 minutes and then pause for huffing and coughing.
Okay.
So yeah, so this is only 2 minutes, and patients would wear this for 10 to 20 minutes.
Wow.
Some patients 30 minutes at a time, 2 to 4 times a day.
And they have to be plugged in to a wall.
They have to be plugged in. Yeah. Yeah, they have to be plugged in.
So you can't really move. You can't really talk on the phone or with other people.
Or eat. Eating would be difficult.
Oh yeah.
Eating would be difficult. Right? You want to really concentrate and do the therapy at the time.
And how many times a day are patients doing this?
So when patients are in the hospital and in the middle of an exacerbation, we want them to do their airway clearance 4 times a day.
It's a lot.
It is a lot.
And when they're home, it's 1 to 2 times a day?
2 times a day, preferably, but yeah.
That was an experience.
You've got more work to do, though.
I know.
After you're done with your vest treatment, right? This kind of did the work inside your chest, right? Now your job is to do some huffing and coughing and move whatever we've loosened up with the inhaled medications, hypertonic saline, pulmozyme, and now your vest therapy. Now it's your job to huff and cough.
Okay.
So a huff
Yeah.
is like a cough, right? When we cough, we close our glottis, we make a hard K sound in the back of our throat. A huff cough is keeping everything open. So it's a
Okay.
like that.
Yeah.
Right? Hi,
Hey! What do you have for me?
I have an aerobica for you today.
What's an aerobica?
An aerobica is an oscillatory PEP device for you to use for airway clearance. So what it's going to do is give you a little bit of resistance when you blow out through it, and it's also going to oscillate.
Okay.
So what that's going to do is help thin and loosen mucus and help get any air behind any pockets of mucus that you might have in your lungs to help you get it out easier.
Okay. How do I do this?
So this is your mouthpiece.
All right.
You're going to put that between your teeth, lips tight. You're going to take a big breath, and you're just going to blow nice and gentle.
How long should these treatments last for? And like how many breaths?
Yep. So a treatment with an aerobica should last about 10 to 15 minutes. Okay. You want to do about 10 exhalations right in a row.
Okay.
If you can, if you're not getting dizzy or lightheaded while you do it. And then after you're done doing 10 blows, you're going to take a break and you're going to do your huffing and coughing.
Okay. And if you have a patient in the hospital that for whatever reason isn't tolerating the vest, you could have them do the aerobica
Absolutely.
instead.
Yep.
Great.
If it's a patient who had some sort of chest surgery or a chest tube or something like that, yes.
Awesome. Thank you.
Okay. So manual percussion is a manipulation of the chest wall, either with hands, cupped hands, or with something called a palm cup. And essentially what you're doing is cupping the chest wall anywhere where the rib cage is, with a cupped hand or the palm cup, to send vibrations through the soft tissues that help thin and loosen mucus. Sometimes a patient might be like, I have a plug and I can feel it like right here. Can you do some chest PT in one specific spot? So imagine you're doing chest PT, you're really concentrating in one specific area when you're doing it.
Okay.
So it can take a long time if you're doing a full treatment and doing every lobe of the lung. So can I do some on your chest?
Sure.
Would that be okay?
Yeah.
Just because you're sitting up, I'm going to do here.
It feels nice.
The palm cups makes that pocket of air for you.
Okay.
So then you can almost be a little bit more aggressive because you know it's going to work every time, right?
Now we have covered some background on CF, antimicrobials, and airway clearance. There are a few other important points. In addition to previously mentioned therapies, adequate nutrition is vital for preserving and improving lung function. To this end, there are some things you should keep in mind. Be sure to continue any nutritional supplements while patients are hospitalized. Do not hesitate to consult the nutrition team with questions or concerns, and consider calorie counts in patients that have been experiencing unintended weight loss. Continue prescribing patients their pancreatic enzyme replacement therapies. For individuals with CF-related diabetes, do not order a diabetic diet and traditional sliding scale insulin reflexively. CF-related diabetes is different from type 2 diabetes. You are probably used to reducing insulin doses and converting mealtime insulin to sliding scale for most of the diabetic patients you see. For CF patients that are able to tolerate full meals and are receiving nutritional supplementation, it's best to keep them on a very similar insulin regimen to what they do at home. If you're not sure what that is, ask them. Because of the importance of adequate caloric intake and the risk of malnutrition, a traditional diabetic diet is often very limiting. One note about medication reconciliation is that you may see that the patient is on modulator therapy. Modulator therapies enhance the function of a defective CFTR protein in individuals with certain genotypes. They have been shown to improve lung function and reduce symptoms and pulmonary exacerbations. There are 4 drugs currently available when this video is made: Kalydeco, Orkambi, Symdeko, and Trikafta. What is important for you to know is that we often will stop these medications during hospitalizations for pulmonary exacerbations because of potential for drug interactions with some of the antibiotics and other medications we use. Do not routinely order them upon admission. Rather, discuss their utility and when to restart them with your pulmonary consultants. Prior to discharge, patients will typically have repeat PFTs done in the hospital to make sure that their FEV1 is improving. We hope that this video may help you feel more comfortable caring for this unique patient population. Individuals with CF are often very knowledgeable about their disease. Most have spent several hours every day since they were a child doing therapies and managing their condition. Take time to learn about their experience and ask them questions about things you may not be familiar with. You will not regret it. A few main points to hammer home. Review prior sputum culture data to guide therapy. Double cover Pseudomonas. Airway clearance therapies should be happening 4 times daily, with close attention paid to the order of therapies so that they are most effective. Do not routinely order a diabetic diet or replace the patient's insulin with sliding scale insulin. Continue nutritional supplements in most cases. Don't be afraid to ask for help from the pulmonary service, nutrition team, respiratory therapists, nurses, and most importantly, the patients, who have much to teach. Thanks for watching.